ഒന്ന് കേട്ടൂടല്ലോ ക്ലാസ്?
നമ്മൾ ഒരു മാസം കൂടെ ലീവ് കൊടുത്താൽ അല്ല ഒരു വർഷം ഓക്കെ കയറാൻ പറ്റും. ഇത് ഒന്നി വെച്ചിട്ടാണ് ഇല്ലെങ്കിൽ ഞാൻ അമ്മ ഓഡിബിൾ കേൾക്കാമോ? ഞാൻ പറയണ കേൾക്കുന്നുണ്ടാ? Good afternoon. Anybody respond?
Yes, sir. Kelka. Good afternoon.
You can hear. Okay. So very good afternoon to all.
Yes, sir.
So our my PowerPoint is visible.
No,
കാണാമോ?
sir. No,
Eh?
sir. ഇല്ല
No.
സാർ വീഡിയോ മാത്രമേ ഓണുള്ളൂ.
വീഡിയോ ഓണാണ്. രാമേ നീ ഇപ്പുറത്ത് പോയി ഓപ്പൺ ചെയ്യണം. അനീം Is it visible now? ഓ ഷെയർ ചെയ്തില്ല. ഓക്കെ. Is it visible now? കാണാമോ?
യെസ് സർ കാണാം.
കേൾക്കാമോ?
യെസ് സർ.
കേൾക്കാം. Okay. Very good afternoon to all. First of all, so Dr. Shanavas on behalf of Department of Pediatrics. So today's our aim is to have a class on growth abnormalities in children. So is it audible?
Yes, sir.
Okay. So our plan for the next few days is we will take the first 10 chapters of OP Guide and you will have a end-posting exam. Not end-posting exam, there will be then you will have the first average. So what you have to do is now the first 10% should open their videos. First 10 numbers open their video. So it will be an interactive session so that you will not sleep. Abhirami is there. Okay, very good. Abhinand. Abhinith, where is Abhinith?
Yes, sir.
Okay, quick, so that I didn't have my lunch. I thought I will have the class from 2 o'clock. You all had your lunch, isn't it? Now ready for sleeping. That's why I'm asking to switch on all the videos. Okay. So I will start with what is today's class will be on these following. I will discuss what is growth. അത് കറക്റ്റ് ചെയ്യാം, അത് കറക്റ്റ് ചെയ്യാം. ഇതിൽ അത് കറക്റ്റ് ചെയ്ത് അത് പവർ പോയിന്റ് എടുത്താൽ പ്രശ്നമാണ്. കാണാൻ You meeting in what? Share screen. Yeah. Share screen. Video. Oh, finally. So, കേൾക്കാമോ?
Yes, sir. Welcome, sir.
കേൾക്കാം. Okay. So, thank you. So, once again, welcome. So, we'll be dealing with the abnormalities of growth, because abnormalities of growth, you are not very much familiar with the growth. I will be dealing something regarding growth, then we'll go for abnormalities of growth. So this is our plan for dealing with today's class. So I will first discuss about what is growth, then what are the factors that affect growth, and what are the laws that decide growth, and what are our parameters we should monitor, we should look when we assess the growth. And the main topic is for regarding abnormal growth. So by definition, growth means increase in size or mass of the body. So a related term is development, and that will be dealt in the next class. What is another abnormal development? Development means a maturation of a function. Maturation of a function is development. And on the other hand, increase in size or mass of tissue is called growth. So how growth occurs is it is because of the increase in number of cells or by increase in size of the cell. So hyperplasia and hypertrophy of the cells will lead to growth. So what are the phases of growth? When we are concerned about growth, growth starts in the intrauterine period. So it starts in the first 14 days is called an ova. So in the first 14 days of life is an ova. When the ovum fuses with the sperm, it forms an embryo. From second week, that's from 14 days to 8 weeks, it is called an embryo. So nowadays there is a specific learning. Embryology is a specific learning stream is also there. So you can have embryo. Then for subsequently, from 9th week to term is called fetus, and from first 1 year is called so 28 days is a newborn. So here again, a neonatology is a study of newborn, and infant is less than 1 year, toddler 1 to 3 year, preschool child 3 to 5 or 6 years, from 6 to 12 years it is a school going child, and 13 to 18 years is an adolescent. So in all these periods, what is the basic problem? Basic character is there is growth, that is increase in size occurs in all these up to adolescence. Then everything is attrition. So it is what is apoptosis increases and reduces. So is am I audible?
Yes, sir.
Am I too fast?
No, sir.
Clear also. Okay. So coming to the growth occurs in intrauterine growth and also postnatal growth. So the parameters, the factors that affect growth when we consider the intrauterine growth is decided by maternal factors, placental factors, and fetal factors. You know, maternal factors, age of the mother. If the mother is very young, growth may be, whether it's less than 18 years, growth may be affected. Mother is very old, again affected. Mother's nutrition, in the form of short stature mother, very stature or a very malnourished mother, there is problem. Any mothers with medical illness, there are problem. So all these are the maternal problems that decide or that will affect growth of a child. Next is placental factors. You know, the placenta is the medium by which the maternal blood is, or maternal blood and nutrition, oxygen is reaching the baby. So if there is a small placenta, there can be problem. Placental infarct, placenta previa, pasa previa, like that. So many anomalies of placenta can also lead to problems in the fetus. Then inherent fetal problems in the form of genetic problem, disease defect in the problem in the fetus, a genuine genetic defect in the form of trisomy or trisomy 13, Edwards, like that. Any problem in the fetus, a twin delivery, an intrauterine infection, all those problems again produces fetal problem. So these are the intrauterine parameters that will affect growth of a fetus. So next is postnatal growth. So in the postnatal growth, we will divide into 3 phases: infant, childhood, and puberty phase. Infant, childhood, puberty. That is called ICP model. So in the infant, the most important parameter that affect growth is Aparna, yes. What is the most important parameter in infant growth is affected?
Weight, birth, weight.
Okay, is it nutrition? Milk and water. Okay, it is nutrition. So if the patient is getting adequate nutrition, most of the children will grow properly in the first 1 year. In the second year, that is from childhood, from 1 to 3 years or 1 to 6 years, what are the parameters? Next number are Aparna number and photo, audio, video. Video first 10 numbers. കേൾക്കുന്നുണ്ടോ? ഓഡിബിൾ ആണോ?
Yes, sir.
പിന്നെ ഇത് പറഞ്ഞ കേൾക്കാത്തത് ഫസ്റ്റ് 10 നമ്പറിന്റെ വീഡിയോ ഓൺ ചെയ്തോളാം. Okay, in childhood, the most important parameters are hormones. That is growth hormone and also the thyroid growth hormone. So, and in addition to nutrition. So that is the postnatal growth. The last one is puberty. So in addition to growth hormone, thyroid and nutrition, that is sex hormones are also important. Okay. Sri Lakshmi, what is IUGR? Expand IUGR and SGA.
Intrauterine growth restriction.
And small for gestational age. So these are the if the baby is if in utero itself growth is retarded, the postnatal growth is also affected. SGA, that same word. These are 2 words that are used interchangeably. So in IUGR babies and SGA babies or SGA babies, they will have growth affected. So hormonal influence, I have already said. In utero, growth is Sanath Johnson.
Yes, sir.
What are the intrauterine growth in affecting the hormone? Intrauterine, extrauterine we said regarding growth hormone, thyroid, എല്ലാം പറഞ്ഞു. Extrauterine എന്താ പറഞ്ഞ? സനത്ത് പറഞ്ഞാലോ, ഞാൻ കേട്ടില്ല.
ഇല്ല പറഞ്ഞു സർ.
It is insulin-like peptides and placental growth hormones. The placental growth hormones and insulin-like peptides. These are the growth hormones that is affecting the in utero. In the infancy, we said nutrition plus thyroid. Childhood, we said thyroid plus growth hormone. Puberty, we said sex growth. These are the hormonal. So many hormones influence growth. Infections. So any child is getting repeated infections in the form of tuberculosis or diarrhea or recurrent pneumonias. So these children will grow less intense. So that is importance of infections in childhood. Socioeconomic factors, children from poor socioeconomic status will grow poorly, and children from good socioeconomic status grow normally. Emotional factors are also very important. If there is a child is emotionally deprived, even if the child gets good nutrition, child will not eat those things. Their feeding habits are very poor, and that leads to growth retardation. So emotional factors. So these are the factors that affect intrauterine and extrauterine growth. So the extrauterine growth is mainly by, you can roughly call it as ICP model. The genetic factors, IUGR, hormonal influences, and infection can produce problem. Okay. Coming to what are the laws of growth? Growth and development of children are a continuous and an orderly pattern. Growth occurs as a continuous and an orderly pattern. So, as you all know, growth is a cephalocaudal progression. Head appears, head grow first, then subsequently body parts grows. So that is called a cephalocaudal, and also from the limbs grow first more than the shoulder region, like that. So like that, the growth occurs in an orderly and continuous pattern. Each individual grows separately. So you can't compare. If the mother is saying the other child is the neighbor's child is growing very fast, very, very big. So they again the same age. It is not comparable, but each individual has its own growth potential, and different tissues grows differently. For example, you can see here. Sorry. So here you can see the growth. So there are 4 important tissue growth are shown in the graph. So for example, this is the somatic growth. So somatic growth is initially there is a peak from 0 cells to 3 kg at birth. Then it is grows continuously first 2 weeks, first 1 year from 3 kg to 10 kg. Then grows progressively, but it's steadily, not a rapid increase. Here there is a first 2 years there is a rapid increase, then steady growth. Then again at adolescent period there is a rapid growth. So that is a somatic growth. And brain growth, the first 2 years, by 2 years, 90% of the brain growth occurs, and thereafter it is plateaus. So that is a brain growth. And regarding the lymphoid tissue is the maximum occurs around 8 to 10 years of age. 8 to 10 year lymphoid, all the lymphoid tissue increase in size, then it decreases. And the gonadal growth is, the gonads grows without only from 12 years onwards only, or when the patient became adolescent, there is a gonadal growth occurs. So this graph, this graph, when there was a draw and label questions were asked, when we used to ask draw and label, we may ask to draw the somatic growth or gonadal growth, like that may be asked to ask a question in the exam, theory exam. Seven. The move in ഇങ്ങനെ പോയിരുന്നത് മൂവാവുന്നില്ല, അല്ല അടുത്ത സൈഡിലോട്ട് പോകുന്നില്ല. ഒന്നുകൂടെ ഷെയർ ചെയ്യണം. So, so there is some technical snag, no problem. Okay, it goes. So, what are the parameters you will consider for growth assessment? So the parameters we consider are, one is weight. Second, weight, as you all know, weight is measured by routine weighing machine. Usually nowadays we use electronic weighing machines, and you measure the weight of a child, and you should compare with the what is the required how much weight is required for that age, and you classify accordingly. Take the length using a stadiometer, or a length is taken by an infantometer, or height by stadiometer, and calculate the expected. And weight for height. So for a 100 centimeter height, 100 centimeter height is attained at 4 years. There should be 16 kg. If it is less than that, we will consider it as weight for height is low. That is called, otherwise called wasting. And we can consider you should calculate the body mass index. So weight, I will be dealing some bit more in the next slide. So at birth, usually the birth weight of a child is Maria Tom. Maria Tom is the host. Maria.
Yes, sir. Yes, sir.
What is the birth weight of a normal baby? So I think you people are sleeping. Talking to a wall. That's why I'm asking questions, whether there is some responses we are getting or not. What is the birth weight of a newborn?
2.5 to 4 kg.
Very good. So it is 2.5 to 4 kg. You have finished your pediatric posting. Are you? Okay. So an increment of weight occurs in each year. There should be 200 gram of increment of weight each week, and usually roughly 1 kg or 800 to 1 kg per month. And weight gets doubled by 6 months, and triple by 1 year, and quadruples by 4 years. Okay, so you calculate weight by formula, what is known as a Veach formula, that is 2x plus 8 till 6 years. 2x means age. So a 4-year-old child will have 2 into 4, 8 into 8, 8 plus 8. So 16 kg. That's how you have to calculate. And you calculate the weight of the child. If the patient is 16 and calculated is also 16, it is 100% of weight expected. So then there is no malnutrition. You can classify malnutrition also. So like that, Abdullah.
Yes.
Okay. So what is the length of a child? Normal length of a child at birth. First number Abdullah. Parnyo. Video on audio on video audio on video on Abdullah.
50 centimeters.
Abdullah. Abdullah on the video.
Sir, 50 centimeters.
Audio illa. Parnyo. Video varathunde. Abdullah video on chedo.
Sir, Allah sir
on ana. Okay. Abdullah, okay. So length is around 50 centimeter. So length of a newborn is 50 centimeter, and it increases first year 25 centimeter. That is became 75 centimeter at the end of 1 year, and next 1 year it increases by 12 centimeter. You can remember half. 25 centimeter in the first year, 12.5 centimeter in the second year, Next again half, 6.25 centimeter in the third year. Thereafter, it is around 5 to 6 centimeter height. Wait, okay. So the weight of a height is, the increment is, you can calculate the height by the formula. Which formula again? 6x plus 77. 6 into age plus 77 will give the expected height of the child. So it's the length or height we can measure. The increment and also I said. So if the height is shorter than the expected for that age, so for a 4-year-old child, the height required is 4 into 4 6 into 4 6 into 4. I mean, sorry, 6 into 4. So this 48 plus 77. That is the height required for a child. If it is less than that, you will consider it as short stature. So it will be, that is the importance of learning this one. Then head circumference. Abhay. നമ്മൾക്ക് ചിലപ്പോൾ തീർക്കണ്ടേ? എപ്പോഴും ഓൺ ചെയ്തോ? അഭയ്, അഭയ് ഇല്ല. അഭയ്, പറഞ്ഞോ. ഹെഡ് സർക്കംഫറൻസ് അറ്റ് ന്യൂ ബോൺ. ഇത്ര താമസം ഉണ്ട്, ചിലപ്പം പറഞ്ഞു പോവല്ലോ. This is for not for answering, but because there should be an interaction, otherwise everybody will be sleeping. That's why I'm asking. I will also going to sleep. Okay, that's why I'm asking. You not just I can see you and just tell something. No problem. No, the answer is not at all. No need for right answer, because you are very much fresh in this field. So there is no problem. Okay. You just, I want to see you. That's all. Okay. The head circumference of a newborn is usually 33 to 35 centimeter is the head circumference of newborn. The increment of head circumference is 12 centimeter in first year. That the increment is like this. In the first 2 months, first 3 months, it is 2 centimeter per month. Next 3 months, it is 1 centimeter per month. Next 6 months, it is 0.5 centimeter per month. So total, first 3 months, 3 into 2, 6 centimeter. Next 3 months plus 3, that is 1 centimeter per month. So that is 9 centimeter and at the end of 6 months. And then 0.5 into 6, that is 3 centimeters. So total 12 centimeter increments. So head circumference also you should calculate like this. Okay. So we said about weight, height, head circumference, chest circumference. Usually at birth, chest circumference is 3 centimeter more than the head circumference. At 1 year, head circumference equals to chest circumference. Okay. In cases of malnutrition, this will not occur. Then upper segment, lower segment ratio. So I'll be coming when we deal with the short stature. Upper segment is from vertex to pubic symphysis. And from pubic symphysis to foot, end of the foot is lower segment. The ratio at birth is 1.7:1. And at 6 months, it is 1.6:1. 6 months. At 3 years, it is 1.3:1. At 7 to 10 years, it is 1:1. You can extrapolate the remaining values in between. For example, a 5-year-old child will have 1.2:1. Head circumference, upper segment, lower segment ratio. The importance of learning this upper segment, lower segment ratio is, if you are seeing a short stature and you know for example, a 4-year-old child is coming with a short stature and you are measuring the height as 75 centimeters, that is correspond to 1 year height. And you are looking for the upper segment, lower segment ratio. This 1.2:1. 1.2:1 is normal for a 4-year-old child. So then it is called a proportionate short stature. Upper segment and lower segment is proportionate for the height or for the age. So that is called proportionate short stature. And another one is disproportionate short stature. If the height of the child is 4-year-old child, again, height is 75 centimeter. The upper segment, lower segment ratio is 1.5:1. That is, it is around 1 year in the height, upper segment, lower segment ratio. It is a tall upper segment. So you should consider short limb dwarfism. The trunk is normal. That is, upper segment is normal and the lower segment is short. So that's the importance of knowing upper segment, lower segment ratio. It's going now smoothly now. Smooth. Okay, next parameter is anthropometric parameter is arm span. Arm span is measured by patient should be kept stand in front of a wall and the arms are stretched, and you may measure from tip of the middle finger to the other middle finger. So that will give you the total arm span. Normally, arm span is 1 to 3 centimeter more than the height at 1 to 7 years, and arm span is equal to height at 7 to 10 years. Around 10 years, arm span is equal to height. After 10 years, the arm span is more than height. In the first 7 years, the arm span is 1 to 3 centimeter less than the height, and arm span is equal to height at around 10 years. Arm span is more than the height after 10 years. So if it is not like that, so if it is in the case of Marfan syndrome, in case of homocystinuria, like conditions, the arm span will be always more than the height by 5 centimeter. If it is more than 5 centimeter, we will consider it as arm span more than height. So conditions are Marfan syndrome, homocystinuria, arachnodactyly, Klinefelter syndrome, like conditions. These conditions, arm span will be more than the height. Then mid upper arm circumference or MUAC. So MUAC is measured patient sitting or standing, hands hanging on the side. You should measure the acromion and olecranon process, take the mid position. So the mid upper arm circumference is usually more than 13.5 centimeter. It is measured between 6 months to 60 months. That is half an year to 5 years. All the normal ranges are there. So if it is less than 13.5, it is mild malnutrition. That is 12.5 to 13.5 is mild malnutrition, and 12.5 to 11.5 is moderate malnutrition. This MAM, and less than 11.5 is a severe malnutrition. So mid upper arm circumference also you should measure. Then dental growth and bone growth. These are the parameters you'll be coming regarding dental growth and bone growth subsequent slides. So you should measure weight, height, weight for height or BMI, then mid arm circumference, chest circumference, head circumference, then arm span. These are the 7 parameters that you should measure clinically, and you can look for a dental, how many teeth are there, and you can look for, and bone age by X-ray. So these are the ways you should assess the growth of a child. You may be asked in a essay question like this: write about the growth of an 1-year-old child. Write the growth of an 1-year-old child. It may be a question in the exam. So you have to write the 1-year-old child should have a weight of 10 kg, height of 75 centimeter. Weight for height will be 75 centimeters should have 10 kg. BMI should be measured. BMI formula is weight in kg by height square. Weight in kg by height in meter square. So BMI should be measured. Then head circumference. The child should attain head circumference of 47 centimeter at 1 year. Chest circumference should also be 47 centimeter. Upper segment, lower segment ratio should be around 1.5:1. And mid arm circumference should be more than 13.5 centimeter. arm span should be 1 to 3 centimeter less than the height. And how many tooths should be there will be coming in subsequent slides. Okay, so these are the ways you have to write in a growth assessment. Okay, so when you are taking a growth of a child, so for example, you are taking weight of a 4-year-old child. So here, this is called growth chart. This is an IAP growth chart. The pink is for pink. Midlage, pink and pink is for midlage. Pink color midlage.
Yes, sir.
Can't midlage. Video. Okay. Right. And then very good. Midlage. Okay, see. Okay. This pink color pink is for anybody? For female. Pink color female. So female growth chart and black is for red color. So 4-year-old child. Usually you are taking as only 4-year-old child in 10 kilo. You mark here. Can you see the arrow? Okay. You mark here. So the lowest line is 3rd centile, below 3rd centile. Indicate he is in malnutrition or severe malnutrition. Okay. And ideally, if there is a, if you are taking height of the child, 4-year-old child should be 100 centimeter. Instead of that, it is only 7. You presume that it is 85 centimeter angle. It is short stature. So in that case, what is the height age of the child? If a child in a 85 centimeter, so you draw a line from here to the 50th centile. 50th centile താഴോട്ട് വരച്ചാൽ, so 1.5 വയസ്സിന്റെ ഹൈറ്റേ ഉള്ള. That is called height age of the child. മനസ്സിലായ? മിഥിലാജിന് മനസ്സിലായ? നമ്മൾ ഒരു പേഷ്യന്റ് ഹൈറ്റ് എടുക്കുന്നു. 4-year-old child. You are taking height. Suppose that the child's ideal height is 100 centimeter. So 100 centimeter 4-year-old child എടുത്ത 100 centimeter എടുത്ത, it is, see, 50 centile is in the 100 centimeter. 4-year, this is 100 centimeter. 100 centimeter നമ്മൾ correct മിഡിലോട്ട് വരയ്ക്കുമ്പോൾ it is the 50th centile. Instead of that, if the patient is having or 85 centimeter or height is of 85 centimeter, 85 centimeter. Line, it is 85. That line is plotted laterally to 50th centile. 50th centile, you draw vertically down. And the height age and 1.5 വയസ്സിന്റെ in the height. This is the way you have to draw a line and draw in it. So when you are coming to the clinical posting, you should take height and weight and plot in the growth chart. So in the logbook also we have provided this growth chart. So these growth charts are for assessing the height and weight of the child. There are head circumference charts are available. There are body mass BMI charts are there. So many other types of charts, growth charts are there. Growth charts can be asked as a short note also. Next, another parameter that you should monitor is, that you should look is target height. Target height is what is the average height of that child patient that child will attain when he is 18 years. So that depends on the parent's height. So you calculate you measure the height of the father, height of the mother divided by 2, plus 13 for boys and minus 13 for girls. So here it is a plus 13 for all divided by 2 will give you a target height. Example, if your patient's height is now 85. So if you calculate the height of the target height should be calculated. Age of the father, height of the father, height of the mother, plus 13.5 divided by 2. So it's a male child. So you will get a height. So that height you plot in the 18 years. 18 years in the height will plot here. Okay. If the baby's height is the same centile, suppose the target height plot that height is in the less than the 3rd centile on Nikina angle, it indicates that it is a familial short stature. Patient is growing in par with the parents. So that is a familial short stature. That is the importance of target height calculation. So that is what is target height, height of the father plus height of the mother plus 13 for boys and minus 13 for girls, all divided by 2 will give the target height. The target height you should plot in the 18-year in the growth chart, and in the and it should be around just there is a some slight variation will be there. 13.8 centimeter height more or low can be there. There will be a range like this. Okay? So if it is in the same range, there is no short stature is familiar short stature. Okay, so that is regarding mid parallel height. Okay, so coming to something regarding bone age. Bone age is assessed by noting the appearance and fusion of the epiphyses. Appearance of epiphyses at birth, there are mainly 3 epiphyses will be there. One is lower end of femur, upper end of tibia, calcaneum, foot bones. These are the 3 bones consistently present at birth. So if you want to assess the bone age of a child, if you want to know the age of the child, the newborn is term or not, full term or not, you should take the X-ray. If it is there, all the centers are lower end of femur, upper end of tibia, it's a term. Maybe there is no displays in the. So as age advances, the newer and newer epiphyses appears. So usually the first epiphyse appears in the hands. That is the carpal bones appear first. So the number of carpal bone, a child should have age plus 1 carpal bone. That is, a 1-year-old child should have 2 carpal bone. 3-year-old child should have 4 carpal bone. You take the X-ray of child. You can see the X-ray of this child. So Joshua, what is the age of this child?
Sir,
Child should
3
have
years.
age
3
plus
years.
1 carpal center. So here, how many carpal centers are there?
2.
2 carpal. So age 1 year.
1 plus 1 year.
1 year. Or carpal bone minus 1 is the age. Okay. So there are so many types of ways you can avoid, you can assess the carpal bone, assess the bone age. These are called Grulich and Piley chart and Tanner-Whitehouse chart. So these are the charts that are used for assessing the bone age of the child. A child is coming with the short stature. You are taking the X-ray of the left hand. You are taking X-ray of left hand and look for and compare the that left hand with a 3-year-old child's X-ray. So that X-ray will be given as atlas. So this is a Grulich and Piley atlas for assessing the bone age. Tanner-Whitehouse atlas. Okay. So that is regarding bone age. Coming to dental age. So a child should have 30 milk teeth. Okay, 30 milk teeth, that is deciduous teeth. It will be complete by 20 milk teeth, which is complete by 30 months. Tender Vaisama should have all the 20 milk teeth should be there. If it is delayed, in case of hypothyroidism and other conditions can be delayed. Okay, then regarding the permanent teeth. So the teeth in the first permanent teeth that appears in the lower central incisor. First teeth that appear, first permanent tooth that appears is lower central incisor at around 6 to 7 years. Okay. First deciduous tooth. First permanent tooth is first molar at around 6 years. Okay. So by counting the number of teeth also, you can indirectly assess the age of the child. So coming to our topic proper, that is abnormal growth. So today we will be dealing with the short stature, tall stature, failure to thrive or obesity. That is short stature and tall stature are for height parameters. Failure to thrive is for weight parameter and obesity is for overweight. And microcephaly. Obesity we are not going to touch today because it is a separate entity. So coming to short stature, what is the definition of short stature? Definition of short stature is a height or length below more than 2 standard deviation for that particular age and sex is called a short stature. So you should know what is a standard deviation. Standard deviation means, you suppose you are taking 130, your class has got 134 or 124 students. You are taking the length of the 134 students today, and you are plotting graphically. So in that case, majority of the children will have height around the normal range. Okay, so that is medium. And you will get if you are arranging it in ascending or descending order, you will get what is called a bell-shaped curve. Okay, so which this this red in the left side is less than the normal, more than normal. It's the right side, it's more than normal. So if it is for all anthropometric parameters, you consider 2 standard deviation more than above the median. This is a median value. Median value in a column more than 2 standard deviation above normal or below normal. Above normal is short stature. Below normal, above normal is tall stature. Below normal is tall stature, short stature. Mansilaya. Ashwin Aravinda, Mansilaya. Standard this standard deviation the concept Mansilaya Ashwin. Ashwin onda. So standard deviation a lot of population you are assessing, you are arranging it in the 13 years bachelor students almost same age height ascending or descending order there will be a bell-shaped plot, and if it is more than 2 standard deviation above normal will be tall stature, more than 2 standard deviation below normal is short stature. More than മനസ്സിലായല്ലോ. ഈ സ്റ്റാൻഡേർഡ് ഡിവിഷൻ ഒരു സ്റ്റാൻഡേർഡ് ഡിവിഷൻ എന്ന് പറഞ്ഞാൽ ഇവിടെ വരെ വരും, രണ്ടാമത്തെ സ്റ്റാൻഡേർഡ് ഡിവിഷൻ ഇവിടെ, മൂന്നാമത്തെ സ്റ്റാൻഡേർഡ് ഡിവിഷൻ ഇവിടെ. വാല്യൂ വെച്ച് നടക്കുകയാണെങ്കിൽ will be coming to value, or velocity of growth is consistently below 25th centimeter is also will consider it as short stature. Another is based on the mid parallel height, MPH. Mid parallel height നമ്മൾ നേരത്തെ പറഞ്ഞല്ലോ. If the mid parallel height is below the 2 standard deviation also is ഈ പേഷ്യന്റിന്റെ ഹൈറ്റ് കൊച്ചിന്റെ അച്ഛന്റെ അമ്മയുടെ മിഡ് പാരന്റൽ ഹൈറ്റിന്റെ അതായത് ടാർഗറ്റ് ഹൈറ്റിനെക്കാളും 2 സ്റ്റാൻഡേർഡ് ഡിവിഷൻ ബിലോ ആണെങ്കിലും ഷോർട്ട് സ്റ്റേച്ചർ ആണ്. These are the 3 definitions for short stature. So the height below third centile എന്ന് പറഞ്ഞാൽ 100 പേര് 100 ഈ 123 പേര് നമ്മളെ അതായത് 100% 100 പേര് നമ്മൾ ഒരേ ലെവലിൽ നിർത്തുന്നു. എന്നിട്ട് അവരുടെ ഹൈറ്റ് നോക്കുമ്പോൾ 3% will be below average. That is called third centile or more than 2 standard deviation. Centileum standard deviation അറിഞ്ഞിരിക്കണം. Okay, it is very bit difficult, but we can. So definition over. Okay, so what are the causes of short stature? We said there are 2 things. One is normal variation, that is familial short stature and constitutional short stature. Familial short stature and constitutional short stature. The pathological cause of short stature are divided into proportionate short stature. Proportionate short stature concept നേരത്തെ പറഞ്ഞു. Upper segment, lower segment ratio will be normal for that particular age. 5 വയസ്സുള്ള പേഷ്യന്റിന് 100 സെന്റിമീറ്ററേ ഉള്ളൂ. 5 സെന്റിമീറ്റർ patient should have 107 centimeter. But his upper segment, lower segment ratio is 1.2:1. That is normal for that age. It is a proportionate short stature. So classical familial short stature and constitutional short stature are proportionate short stature, because we will not consider it as pathological because these are normal variation. Then chronic systemic illness like cerebral palsy, congenital heart disease, chronic respiratory illness like cystic fibrosis, and also bronchial asthma and other chronic illnesses. GIT disease like chronic lung disease, and also malabsorption, chronic lung disease, other diseases like and chronic infections like HIV, TB, endocrine disease like growth hormone. These are the common prototype we use the pathological obesity, growth hormone deficiency, hypothyroidism, Cushing's syndrome, pseudo hypoparathyroidism, and STI babies. We already said STI babies will grow slowly only. So short stature of STA and psychosocial causes. So all these are causes of proportionate short stature, including familial and constitutional. So endocrine short stature, disease of chronic disease and malnutrition, STA, and psychosocial causes. These are the causes of proportionate short stature, where the upper segment, lower segment ratio is normal for that particular age. That is a proportionate short stature. Coming to disproportionate short stature, we said short trunk dwarfism. Trunk spinal area. So it is in MPS, mucopolysaccharidosis, Spondyloepilepticus dysplasia, carry spine-like condition can have short trunk dwarfism or short limb dwarfism in the form of achondroplasia, hypochondroplasia, and rickets. So these are the causes of short limb dwarfism. So short stature, short trunk, short limb dwarfism. How will you approach so regarding familial short stature and constitutional short stature? Familiar, what do you mean familiar short stature is babies, the baby's parents will be short. That is why patient is short. That is genetically predisposed. Ammayum achanum average height ആയിരിക്കും babyക്ക് കിട്ടാൻ പോണം. So parents' height is low, but the child is at birth it is normal, and the growth casts down in the first few months and become the growth velocity will be normal. Yearly velocity. That is yearly we said a child should grow. The height of the child should be around 4 to 6 centimeter. Less than 4 centimeter is short. So more than 6 centimeter is also more. So 4 to 6 centimeter. So cast down growth between birth to 2 years, and height, weight lie in the target mid-parental center. നമ്മൾ പറഞ്ഞല്ലോ mid-parental height in the നമ്മൾ പറഞ്ഞു target height plot ചെയ്തിട്ട് ആ ഹൈറ്റിൽ സെന്റിയൽ ചാർട്ട് ഹൈറ്റിന്റെ ബേബിയുടെ സെന്റിയൽ ചാർട്ട് നിന്നാൽ ഇറ്റ് ഇസ് എ familial short stature. Here we said baby will be growing between 4 and 6 centimeter after 2 years, and upper segment lower segment ratio will be normal. Bone age, നമ്മൾ എക്സ്റേ ഹൈറ്റ് എക്സ്റേ നോക്കിയാൽ bone age will be ബോണിന്റെ ഏജ് will be equal to chronological age. 6 വയസ്സുള്ള കൊച്ചിന് 7 സെന്റർ കണ്ടിരിക്കും. That will be the bone age of the child, and puberty is achieved appropriately, and final height will be the target height, average of parent's height. That is a familial short stature. You may be asked as a short stature. It's a short note on familial short stature. So it is because parents are short, and child will be normal at birth, and cast down growth occurs between birth and 2 years. After 2 years, child's growth velocity will be normal. Upper segment, lower segment will be normal for age. Bone age will be equal to chronological age, and puberty is achieved at appropriate age. So that is regarding familial short stature. Next is constitutional short stature. So that means here parents are, if mid-parental height is normal, protein normal, but there is a history of both parents are small in the early childhood, and as they approach the adolescent, growth spurt occurs, and height and weight become increase and then become normal. That is called a constitutional short stature. Constitutional short stature. So at birth and normal, and they normally till 1 year, and growth shows a deceleration of height and weight and fall below 3rd centimeter. Short stature രീതിയിൽ വരും. Then after around 3 years or 4 years, child start again momentum of growth occurs, and by puberty and adolescent growth spurt occurs. Normally a child during puberty increases, the height and weight increases very dramatically. Around 12 centimeter increment of height occur per year during adolescent period. നമ്മൾ നേരത്തെ പറഞ്ഞു these children will have around 4 to 6, maximum 7 centimeter per year is the growth velocity. One child is usually increases its height of 4 to 6 centimeter during 4 to, that is 12 years old, till 12 years, till the adolescent. During adolescence, growth spurt increases very dramatically to 12 centimeter in normal also. In case of constitutional short stature, that spurt is very much delayed, so that child will grow continuously for some more time and then attain the growth spurt. Bone age is usually lower than the chronological age, but equal to height age. You should know what is height age. Height age in the concept a child who is 4-year-old child, if he's having only 75, his height, what is his height? What is his height age? Aravind, Ashwin Aravind, a 4-year-old child is having 75 centimeter height. What is the Abhirami? എളുപ്പം പറ, അല്ലെങ്കിൽ ക്ലാസ്സിന് നീണ്ടുപോകും. ഉറക്കം
100 centimeter.
A 4-year-old child is having 75 centimeter. What is his height age? Parana, Abhinami Parana.
1 year.
1 year, very good. Okay, you are following me. That's very good. Okay, so 1 year. So this chronologic age, but you know what is chronologic age? 4-year and chronologic age. So bone age will be lower. The 1 year 4-year-old child should have 5 centers. Instead of that, child may have 3 or 4 centers. Okay. For example, 1-year-old child should have 2 centers, but under center bone age is equal to chronological. It is bone age is equal to 1 year. About 475 centimeter correct. Okay. There is a history of delay in weight and height. So these are the 2 questions that may be asked in routine. So coming to a short stage proper, you should ask by diagnosis by history, physical examination, serial measurement and determination in the growth velocity, and mid-parental height measurement and bone adjustment. All this we have already discussed. We will be going very quickly. So history at birth, what is the birth weight of the child? If this patient is a low birth weight child, the child may grow slowly. Okay, that is an SGA baby. Then patient have, if there is a polyuria, polydipsia, so if a patient is having short stature, you should ask whether the child is having polyuria, polydipsia. In that case, there may be diabetes mellitus, chronic disease, diabetes mellitus, diabetes insipidus, chronic renal failure, renal tubular condition can have these symptoms. A chronic diarrhea, greasy stool, bulky stool, maybe due to cystic fibrosis or malabsorption syndrome. Malabsorption syndrome can have short stature. And neonatal hypoglycemia, jaundice, small penis of less than 2 centimeter at birth indicate hypopituitarism. And hypopituitarism will have growth hormone deficiency and headache, vomiting, visual problem, craniopharyngioma. Craniopharyngioma will grow. When it grow up, it will press on the pituitary, anterior pituitary, and pituitary, and growth hormone production will decrease. Again, for problem occurs. A child with lethargy, constipation, weight gain, hypothyroidism. We said hypothyroidism is a cause of. So hormonal causes we are asking. Growth hormone by 2 ways. By isolated growth hormone deficiency in the form of micropenis, jaundice, like that thing, and due to secondary growth hormone deficiency due to damage to pituitary by asking symptoms of raised ICP by craniopharyngioma, history of craniopharyngioma. Malnutrition, you are taking the nutritional history. Patient is not taking adequate food. This is due to malnutrition. And patient is discordant parents. Patient is in an adoption center or in an orphanage. Those will have psychological deprivation. So that may have short stature. Delayed puberty of parents, constitutional short stature. All these are the things that you should ask in the history to find out the cause. So whenever a child is coming with a short stature, you should ask in detail about these symptoms that will cause short stature. Next, you should measure the height. We said height is measured by stadiometer after 2 years, and this is a stadiometer. So by before 2 years, you should measure infantometer. So when you measure stadiometer, which patient should be in the standing erect with its heel, its buttock, its back, and its occiput touching the measuring rod, and the head plate is pushed down to touch here. So you measure the height of the child. Then you measure the height of the child and plot on the growth chart. Height. This is a height chart. This is a height chart. This is a weight chart. This is a female chart. I already said pink is for female. Height chart, weight chart. Suppose this child is having 4 years. Okay, 4 years and 75 centimeter. You are measuring. You are taking. This is the age. This is the length of the child or height of the child. 75 centimeter. We are taking 75 centimeter. Okay, 75 centimeter for you are marking here. Okay, so you know below this red line it is always abnormal. Patient is having severe short, less than, this is a third centile. So by definition, less than third centile. By standard deviation, two standard deviation. So okay, so if a child is short, then you should take the mid-parental height of the child. Mid-parental height of the child. So mid-parental height is same height of the father, height of the mother divided by 2. Suppose 175 centimeter height of father, 150 centimeter height of mother by 2. This 320 by 2. So the target height is 166 centimeter. So you should target centimeter 160 centimeter value. This is 18 years. You plot the 180 centimeter, 160 centimeter. So 160 centimeter corresponds to here. So patient's height, patient target height is here. Patient is growing only here. So it is in the far below it is not a familial short stature. It is not a constitutional short stature because target height is in the 15th centile. Child is growing below 3rd centile. So it is a short. That's how you should plot the height in the growth chart. Weight also you can plot like that. So take the height of the child and plot in the growth chart and calculate the target height and decide whether it is a pathological short stature or physiological short stature. Physiological short stature, we said 2 things. Number 1, familial short stature. How you should decide? You said it will be below the target height. Then in constitutional short stature also it is below the target height, but it will not be very far below. Next thing is you should measure the upper segment lower segment ratio. If the patient's upper segment lower segment ratio 4-year-old child in a 75 centimeter on the upper segment lower segment ratio is 1.2:1. 1.2:1. It is normal for that age. It is a proportionate short stature. Okay, this is the way you have to. Second thing that you should do. Now, upper segment lower segment. How you should look for the upper segment lower segment ratio? We said in the previous slides, and it is at birth it is 1.3:1, 1.7:1. At 3 years it is 1.3:1. 5 years 1.2 എന്ന് ഓർക്കാം. 1.19 instead of that you can use 1.2:1. 10 years 1:1. The upper segment can be measured from the symphysis pubis down. Mother symphysis pubis down or by taking the sitting height. Okay, sitting height your patient should be sitting comfortably with the hip and angle 90 degree. So 90 degree 90 degree knee joint and hip should be in the 90 degree, and you are sitting and you are, this is a stadiometer, you push down the stadiometer to down. So that is the upper segment will be getting, and you make the patient stand though. So and minus the total length minus upper segment will give lower segment. So the ratio, how you should count the upper segment lower segment ratio. Okay, so these are the growth chart. We said this is the BMI chart. So weight by height square you should measure, and you can plot in the you will get one value. You can plot in the chart, and you can decide this above this red line is are abnormal, overweight and obesity. This is the weight for height chart. Okay, regarding growth chart, height chart is there, height chart is there, weight chart is there, BMI chart is there, head circumference chart also is there. Okay, so this we have already discussed. Now coming to the after history, first history, next anthropometry. Anthropometry you should look for the growth and height and weight and upper segment lower segment ratio. Even look for the arm span also. And now going to the physical examination, you should look for any dysmorphism. The various dysmorphism could be in a pituitary or growth hormone deficiency will be a pointed chin with a rounded faces, can be there with a voice of a high pitched voice, can be there with a short stature. And in the case of a Turner syndrome, Turner is for a female with any female with a short stature, you should suspect Turner. So you can see short stature, there is webbing of neck, there is a loose fold of neck, skin is there, and also carrying angle is increased. So all these features are there in case of a you will have short fourth metatarsal, fourth metacarpal may be short, so discal brachydactyly. So all these can be there in case of a short in the Turner syndrome. We can by physics here. If it is all the features of Turner syndrome is seen in a male, you will consider it as a Noonan syndrome. So Turner syndrome female, Noonan syndrome male. Turner syndrome is an X-linked recessive, is an X-linked disorder. Noonan is an autosomal dominant disorder. Okay. So we shall look for Cushing syndrome. Cushing syndrome, we can see mooning of the face. Then there is truncal obesity and and buffalo hum, all these features. And in case of short trunk, these are all somewhat proportionate short dwarfism, short syndrome, we have already said. Now coming to the disproportionate, that is short limb dwarfism, classically seen in case of achondroplasia. So there will be a short limb, classical achondroplasia, and short trunk, classically seen in case of Morquio syndrome. Or a mucopolysaccharidosis, you can have Morquio and other mucopolysaccharidosis, we can have short trunk. So all these features are the, you should examine the physical examination. You look for dysmorphism and any disproportionate. Then you look for clinical examination, you should look for pallor. Seen in case of chronic renal failure, heart disease, all those conditions can have pallor, can be there. Hypertension, in case of CRF, chronic renal disease, can have hypertension. And raised ICP can have, you should look for these features. Then typical process, we said frontal bossing, depressed nasal bridge, crowded teeth, and small penis in case of hypertelorism. All these are seen in case of growth hormone deficiency. And goiter, coarse skin, central obesity, and stria in case of hypothyroidism. Then also other congenital syndrome we have already mentioned. So you examine, the physical examination should be done. And then investigation, how will you decide investigation? So they are divided into first line, second level, and third level investigations. First level investigations are do CBC. We said anemia will be there. Chronic renal failure can have anemia. Malnutrition can have anemia. Infections can have total count abnormalities. ESR may be elevated in collagen vascular and other systemic disorders. And then bone age should be assessed. We said in detail about bone age, and examination of urine for microscopy for urinary tract infection, and also CRF can show urinary abnormalities can be there. Osmolality, maybe decrease osmolality in diabetes insipidus, increase osmolality in diabetes mellitus. pH is abnormal in case of renal tubular acidosis. All these features you should look for. Then stool examination, you should look for parasite, steatorrhea, focal blood, you should look for. Then RFT, blood urea creatinine should be looked for. ABG, arterial blood gas should be looked for. pH and acidosis. It is abnormal in case of renal tubular acidosis and other conditions. Then alkaline phosphatase is elevated in case of rickets, fasting glucose in case of diabetes, and albumin and transaminase level should be looked for. Coming to second level investigation, mainly on thyroxine, you should look for T3, T4, and TSH. TSH will be increased in case of hypothyroidism. T3 and T4 will be low. And karyotyping of girls should be done in case of Turner syndrome with short stature. You can directly go for a karyotyping. You will see 44, 46 XO. Then coming to level 2 investigation, severe rare conditions are diagnosed here. In case of celiac disease, we said about celiac disease, CD. In case there will be tissue transglutaminase is increased, TTG is increased in case of celiac disease, and provocative growth hormone testing. So growth hormone deficiency is diagnosed by growth hormone assay. So growth hormone is secreted in pulsatile, in pulses. So it will be secreted for some time. After that, it will not be secreted. So in pulsatile, and also in case of when there is a stress, there is maximum growth hormone secretion, of course. So if you want to test growth hormone, you put the child into stress. So usually what we used to give the things that we used to give are that is insulin may be given, clonidine may be given, propranolol may be given, like that. So many drugs are used to give. So the classically we used to give clonidine 100 microgram, 10 microgram per kg. Clonidine is given. First, a basal serum growth hormone is assayed, taken. Then clonidine is given. When there is clonidine, when you give clonidine, hypertension can occur. So monitor closely BP and a half an hour interval. Half, 1, 1.5, 2, 2.5. 5 samples of blood is taken after clonidine and estimate the growth hormone. If any value is more than 7 international units per deciliter, there is no growth hormone deficiency. If it is less than 5, there is severe growth hormone deficiency. So growth hormone testing is done by clonidine challenge test. That is called clonidine challenge test. So growth hormone is assayed first, then clonidine is given, and every half an hour you collect blood and send for growth hormone assay. If the growth hormone is more than 10, growth hormone level is more than 10 international unit per deciliter, there is no growth hormone deficiency at all. If it is less than 5, growth hormone deficiency is less. Okay. Then coming to insulin-like growth factor. So insulin, clonidine, the growth factor acts through the production of insulin-like growth factor 1 and 2. And both these are bind to what is called insulin-like growth factor binding protein 3. So by assaying these three, that is insulin-like growth factor 1 or 2 or insulin-like growth factor binding protein 3, you can screen growth hormone deficiency. But it doesn't, it can be, insulin-like growth hormone can be deficient in some other condition like malnutrition or some anorexia nervosa like condition can have, this may be low. So it is a screening test. If it is low, you should go for the growth hormone testing. And if it is, this growth hormone is low, you should go for a brain for MRI. Brain should be done to look for the pituitary and hypothalamus. The pituitary will be, the anterior pituitary will be hypoplastic and the pituitary stalk will be absent. And you can see that in the MRI. So that indicate growth hormone production is low. Okay, so that is MRI if it is growth hormone is deficient. Then if you are suspecting hypothyroidism, T4, T3, TSH. Bone age should be lower than height age. So we said about what is bone age, height age and chronological. So bone age will be lower than height age. That is lower than chronological age. Chronological 5 വയസ്സുള്ള കൊച്ചിന് 100 centimeter and 1 വയസ്സിന്റെ bone age. That is an endocrine short stature. So the bone age is lower than height age and it is lower than chronological age. It is a endocrine short stature. So if it is a disproportionate short stature, you should look for skeletal survey, and Rickets also you should look for skeletal survey. Okay, management depends on the cause of the patient. If it is hypothyroidism, you should treat hypothyroidism. If it is growth hormone deficiency, you have demonstrated, you can give growth hormone deficiency. Nowadays, pen-filled growth hormone is available. You can give daily subcutaneously in the home itself. And if there is craniopharyngioma, do surgery for removal of growth hormone, for removal of tumor. Sometimes there may be associated permanent growth hormone deficiency may be there. In that case, you have to substitute. And gluten-free diet in case of we already said celiac disease and all, you should give gluten-free diet. This is the management of growth. So here we comprise the growth hormone, comprise the short stature. So short stature, first we said about definition of short stature. 3 definition paranje, you should remember at least one, that is depending on the standard deviation. You memorize the bell-shaped curve, 2 standard deviation below the curve, below the normal is short stature. Okay, then you can what are the types of short stature? For physiological short stature and pathological short stature. Pathological short stature can be proportionate short stature, disproportionate short stature. What are the causes? Then how will you approach? History, anthropometry, physical examination and head to foot examination with the syndromic conditions, investigations and management. So that is regarding short stature. So coming to tall stature, by definition tall stature means more than 2 standard deviation. 2 standard deviation bells curve, more than 2 standard deviation above normal is tall stature. So familiar, it could be familial tall stature. In case of obesity, there can be tall stature. Klinefelter syndrome, there can be tall stature. Marfan syndrome, precocious puberty, and homocystinuria. These are the causes of tall stature. You may be asked in the exam, what are the causes of tall stature? You should remember like this. 4 causes of tall stature, you may be asked as a 1-mark question. Homocystinuria, precocious puberty, Marfan syndrome, Klinefelter syndrome, obesity, and familial short stature. These are the causes. Coming to failure to thrive. Another topic is weight is low. So that is called failure to thrive. By definition, failure to thrive means weight below 3rd to 5th centile. We are centile standard deviation. 100 പേര് weight നിങ്ങളുടെ ക്ലാസ്സിലെ 100 പേര് ഓർഡറിൽ നിർത്തിയാൽ 3% പേര് താഴെ, 3 to 5%, that is centile. 3rd to 5th centile below normal. Or failure to gain weight or appearance. You are measuring weight for 6 months. No increment of weight is failure to thrive. Or previously the child was growing in 75th centile. It is coming down to 50th centile. Falling the weight to major centiles is also failure to thrive. So this is used in age less than 5 years. So failure to thrive in the definitions. Failure to thrive is failure to weight below 3rd or bar 5th centile. 3rd bar 5th centile. Failure to gain weight over a period of time. Then weight in the 50th to 70th centile. Coming to the causes of failure to thrive, is classified into organic causes and non-organic causes. Organic causes we said previously, there will be some underlying medical condition in the form of cardiovascular conditions, GIT conditions, respiratory conditions, all CNS conditions. All these conditions can produce, just like short stature, weight also is low. So in that case, organic causes you can recollect in that order. Non-organic causes, again in the form of short stature also there is a psychosocial short stature. Here also patient is both parents are discordant in their relation. They are fighting daily and bullying the children and beating the children daily. Children are in the orphanage. Like that, there will be short failure to thrive. So in that case, it is non-organic or psychosocial failure to thrive. Okay. So coming to the causes of failure, we said GIT causes. GIT, reflux, malabsorption, bowel disease, pyloric stenosis, neurological, severe mental retardation, cerebral palsy. CNS causes renal tubular acidosis, chronic kidney disease. Cardiopulmonary causes congenital heart disease, cystic fibrosis, asthma, hypothyroidism, diabetes. These are the causes. We said organic causes of failure to thrive. Infectious causes. So many infection can produce failure to thrive. Genetic causes. So many syndromes. Down syndrome, Edward syndrome, Pataf syndrome, Noonan syndrome. All syndromes can produce failure to thrive. Miscellaneous causes like lead poisoning and malignancy. The main causes are poverty, misperception of or lack of knowledge about the diet and feeding. Mother may think that if you give formula, baby will grow very well, but the cost of formula is very high. So she will give diluted formula, and patient ends up with failure to thrive. Lack of breastfeeding, feeding diluted formula, dysfunctional parent relation. These all are the causes that is attributable to failure to thrive. These children present with poor growth, often associated with the development of cognition, also is affected. So you should assess by calculating the weight, height, and weight for height. So you can plot in the growth chart, and you can look for the history of the organic diseases and physical examination regarding organic diseases and investigations. So there is no need of any significant investigation until there is an organic cause is there. So if there is an organic cause is there, you can look for that cause only. So all patients you should do CBC, ESR, urine microscopy, culture, and RFT, LFT, serum electrolytes. And you should do what is called a therapeutic feeding trial. You give proper, appropriate feeding under observation and look for gain of weight. If there is gain of weight is there, it is due to psychosocial deprivation, and the mother is not giving or the patient is baby is not taking. That is a psychosocial short stature. Then based on weight for age, we can classify into 3. 15 gradation 75 to, this is the first classification of malnutrition. So 75 to 90, 60 to 74, and less than 60. So that is the first classification of malnutrition in the and stunting. This is a simple Waterloo's classification we have given. Height for age is taken. If it is more than 95, normal. 90 to 95, first degree, that is mild malnutrition, mild failure to thrive. 85 to 90, moderate, less than 85, 70. Weight for height, we said 1-year-old child should have 10. If it is only 80% of weight for height is there. Okay, 1-year-old child should have 10 kg. Instead of that, only 8 kg is there. 8 by 10 is 80% of weight for height. Other is called wasting, classified by Waterloo's classification. More than 90 is normal, 80 to 85 is grade 1 wasting, 70 to 80 is grade 2 wasting, less than 70 is grade 3 wasting. So failure to thrive is also over. So what is definition of failure to thrive? What are the causes of failure to thrive? Types of failure to thrive, organic and non-organic. Causes of failure to thrive. Investigate according to the cause or do a therapeutic feed. And what is the classification? Management depends on the cause of the condition. Coming to microcephaly and macrocephaly. So my macrocephaly, we said head circumference more than 2 standard deviation above the normal for the age. So mean standard deviation in column, if it the head circumference more than 2 standard deviation towards the right side, more than 2, more head circumference more than 2 standard deviation for the age and sex is called microcephaly, macrocephaly. So when it is a brain matter causes that increment head circumference, we will call it as megalencephaly. This is in megalencephaly, the brain parameters is producing a head circumference increments. In case of macrocephaly, there can be other things. Skull can produce large head in case of hemolytic anemia like thalassemia. Skull enlargement produce large head. That is a macrocephaly. On the other hand, Niemann-Pick disease, Gaucher disease, where the deposit in the brain occurs, that can produce large head. Or simple brain matter, parenchyma alone. So, could be a familial megalencephaly or associated inherited syndrome. Inherited syndrome is a Niemann-Pick, Gaucher, Canavan-like syndrome or neurometabolic diseases. Or benign familial microcephaly. Here, head circumference is increased at birth and persists throughout infancy and upper in the growth curve. Head circumference is in the higher centile. But there is no associated problems in the form of body size. Neurological examination development will be normal. That is a benign familial megalencephaly. Metabolic megalencephaly is, we said the cause of diagnosis could be, it is due to, at birth it is normal and increase after that. MBS, mucopolysaccharidosis, Niemann-Pick disease, Gaucher, all those conditions can have metabolic megalencephaly. Causes of large head could be due to scalp problem can produce problem. In the form of large subgaleal hematoma can produce large head. Skull problem can produce large head because of the hemochromatosis or thalassemia or rickets like condition can produce large head. Then subarachnoid hygroma, subarachnoid hemorrhage can produce large head. Then brain parenchyma, Niemann-Pick, Gaucher, all condition can produce. In the hydrocephalus, fluid collection can produce large head. Like that you can, and also brain tumors, intracranial space opening tumors can produce large head. So these are the textbooks description of large head. So neurocutaneous syndromes, neurofibromatosis, tuberous sclerosis can have large head. So we said Alexander Canavan, then megalencephalic conditions. So all these conditions, it is due to increase in the brain matter due to deposit of these metabolic conditions. Like, so again, again same condition. Then Soto syndrome is a familial condition in the large head in the families it will be going on. Then CSF fluid increase, we said hydrocephalus, benign enlargement of subarachnoid space. Then hydranencephaly is a brain become very much liquid. Then AVM, arteriovenous malformation, subdural abscess, epidural abscess, subarachnoid, increase in bony compartment. We said, so bone, subdural space, AV malformation, brain matter, the ventricular structures, all these can increase, can produce large head. You can remember like this. Okay. Then what is microcephaly? So remember this one. Normally in all examination, we used to ask what is microcephaly. This is the only anthropometric parameter where we use 3 standard deviation norm for the head circumference. So more than 3 standard deviation below normal, because lot of people have small head. In the community, the head size will vary very widely. Only true microcephaly you have to take. That's why 3 standard deviation is taken as a cutoff value for microcephaly. Head circumference more than 3 standard deviation below mean for the age and sex is called microcephaly. Primary microcephaly is due to primary parenchyma itself is low, so that it become small. Secondary is due to some injury or insult to the brain, that will produce decreased brain growth, and that will produce secondary microcephaly. So primary microcephaly and secondary microcephaly. Causes, again syndromic cause, autosomal dominant can be recessive, X-linked condition is there, Trisomies, all trisomies can produce microcephaly. Trisomy 21, 13, 18, monosomy. See other syndromes like Williams syndrome, Cray-Duchat syndrome, Sickle syndrome. So many syndromic causes of microcephaly. Structural disease can produce microcephaly. Metabolic PKU, phenylketonuria is a classic prototype for microcephaly. So many conditions, untreated PKU, neuronal cerebrolipofuscin can produce. The intrauterine infection, torch infections can produce microcephaly. Fetal alcohol, fetal hydantoin, fetal tobacco, using of all these to the mothers can produce microcephaly. Perinatal insult can produce microcephaly. You may be asked as a microcephaly causes then microcephaly causes one. Both can be asked in the as a short note, 1 mark question, 2 mark question, or in the exam, in the practical examination may be asked. Then coming to evaluation. So there is you should look for head circumference and standard should be calculated. And okay, so progressive increase in more than 2 to 3 centimeter. If it is gradually decrease or increase, you have to interfere. If the head circumference is progressively increasing 2 to 3 centimeter per, we said head circumference increment maximum is 2 centimeter. If it is more than that, you should depends on the cause, MRI, CT, or screen. These are the investigations that we should plan in a case of microcephaly. Okay, so we will stop here, and we'll ask some questions. Okay, David Jiju, define short stature. David Jiju. Poonma madam, the class come on.
Yes, sir.
Madam, I will show now. Okay. Okay. 9 many class on time. Okay, I started very late. That's why I am continuing. Okay, David, what is short stature? You get the class.
Hello. Hello, sir. More than 2 standard deviation.
Okay, it is 2 standard deviation below the mean for the age, or 3rd centile, below the 3rd centile. Okay, Abhirami vara kainyu. Then comes Abhirami kanyitarana Adisri. Define microcephaly. Last topic. Adisri, microcephaly.
Yes, sir. More than 3
Okay,
standard
here is a
deviation.
3 standard
Less
deviation
than
below
3
mean
standard
for
deviation.
the age and sex is microcephaly. Then Afsal, what is define the formula for tell that formula for target height. Bhai, target height, the formula for target height. Ungia, Unda Salaton Afsal. Afsal 114 batch channel. Parano. Parayna Afsal. Mungi. Ajila Varnolana. Target height. Ajila.
Sir,
Ah.
parents in the height in the mid.
Height of the father plus height of the mother plus
by
13 by 2 for males minus 13 for
females.
females. Okay. Akhil, how will you diagnose hypothyroidism? Hypothyroidism diagnosis. You could Akhil. Amana Nasser Varnola. Akhil Paradilla. Amana Nasser.
Thyroxine, serum thyroxine.
Okay, TSH will be elevated, T4 free, T3 or T4 will be low. Okay, how will you Amal, how will you confirm the diagnosis of growth hormone deficiency? How will you test growth hormone deficiency? Amal. You can't para Amal. Arjuna Varna, Korpola. How much you gasp no area made matrona? Paradilla. Ami Abraham, growth hormone deficiency.
Hello. Using clonidine.
Okay, using you do a basal growth hormones assay, give 10 microgram per kg of clonidine, assay half, 1.5, 2 hours, 2.5 hours, and value less than 5. Any value less than 5 indicate growth hormone deficiency. What is Anakha? Anakha, and what is the increment of head circumference in the first year? How much centimeter?
33 centimeter to 35 centimeter at birth.
Okay.
Then
12 centimeter increment. That is to become 47. 47. The increment is like this. First 3 months, 2 centimeter per month. Next 3 months, 1
3
centimeter per month. Next 6 months, 0.5 centimeter per month. Total of 12 centimeter per month. Anjusha, when will birth weight get doubles? Birth weight gets doubles. At what age?
5 months.
Okay, very good. Anna Ruth, what are the instruments used for measuring height?
Stadiometer.
Okay, very good. Stadiometer and infantometer. Anshida Sharin, what is MUAC? Expand MUAC. Anshida Sharin.
Sir, what?
MUAC in a explain. Expand MUAC. What is a normal? Mid upper arm circumference. Mid upper arm circumference. Anusri, what is the normal range available for? It is available from 6 months to 60 months. Okay, very good. Thank you. Any doubts? Sorry, Purnima madam, sorry, you can continue. So shall I stop? Any question, doubts?
No, sir.
Okay, thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Sir.